Episode 29 Proximal Control Vascular Surgery Exam Prep Lower Limb DVT Acute and Chronic FRCS and European Board Vascular Surgery Exam Focus Teaching. Welcome back to Proximal Control. I'm your host, Bomia. This is the podcast where we prepare for the vascular exams the same way we practice as a day one consultant, with structure, judgment, and control. Because in vascular surgery, control is everything. Alright, welcome back to Proximal Control. Today we are going deep into the venous system. This episode covers two interconnected and heavily examined topics: acute lower limb DVT and chronic lower limb deep venous obstruction, all anchored on the ESVS 2021 Venous Thrombosis Guideline and NICE Guideline. So let's start. Okay, at the beginning we will talk about acute lower limb DVT, and we'll start with the epidemiology and risk factors. Let's start with the size of the problem because it frames everything else. The annual incidence of a first symptomatic DVT in the adult population is 50 to 100 per 100,000 people. Add pulmonary embolism to that, and the total venous thromboembolism incidence is about 25% higher again. Globally, around 1 million people are diagnosed with DVT each year, and roughly 300,000 die of pulmonary embolism, which is a mortality that exceeds the combined deaths of acute myocardial infarction and stroke in the United States. Age is the dominating demographic drive. Incidence doubles with every 10-year increment in the age. 60% of all VTE events occur in patients over 65, and at least 1 in 12 middle-aged adults will develop a DVT or PE at some point in their remaining lifetime. And notice that the annual incidence of VTE has not fallen over the last 2 to 3 decades, despite widespread thromboprophylaxis. Because at the same time we are operating on older and frailer patients, obesity and cancer are more prevalent, and CT and MRI now detect incidental clot we would previously never have known about. One more number to carry with you, because we come back to it repeatedly. After an unprovoked DVT, the recurrent rate is about 10% in the first year and 30% by 5 to 8 years. So recurrent DVT is a risk factor to have another episode, and you can see that the recurrence rate is about 10% in first year and 30% by 5 to 8 years. Now let's talk about more risk factors. But before I list them, I want to tell you one important thing that you should know, because it runs through the whole of this episode, and it is the single thing that decides how long we anticoagulate. Yes, we're talking about provoked and unprovoked. A DVT is called provoked when we can identify a clear precipitating risk factor. Something that happened to the patient or something that is wrong with the patient that explains why the clot is formed. A DVT is called unprovoked when, after a careful history and examination, no such factor can be found. That is the entire distinction. Provoked means there is an explanation, unprovoked means there is not. It says nothing about how big the clot is or how proximal it is. An extensive iliofemoral DVT can be unprovoked and a small cuff DVT can be provoked. And the reason it matters is straightforward. If we can name the cause and the cause has gone away, the risk of a second clot once anticoagulation stops is low. If we cannot name a cause or the cause is still present, the risk stays high, and that is what drives treatment duration. We will subdivide the provoked group formally when we get to classification in few minutes. So for now, just hold on to these two words. So the acquired factors that provoke a DVT are cancer, acute medical illnesses, surgery and trauma, immobility typically in hospital and typically lasting at least 3 days, obesity, inflammatory disease and infection, estrogen-containing hormone therapy, pregnancy and particularly the postpartum period, long-distance travel, recent hospitalization, and antiphospholipid syndrome. Two important points worth knowing is primary varicose veins are a minor risk factor only. Do not overstate them, and prolonged computer-related seated immobility syndrome is now recognized as a genuine risk factor in its own right. Hypertension and diabetes are also risk factors for VTE, but far less prominently than they are for arterial thromboembolism. Then the inherited factors, and here the ranking surprises people. The most common inherited risk factor is not a classic thrombophilia at all. It is non-O blood group, which roughly doubles the risk of VTE. Next commonest is heterozygous factor V laden, which increases risk by a factor of 3 to 8 in selected populations. And then the group we label severe thrombophilia, such as homozygous factor V laden, deficiency of antithrombin, protein C or protein S, and antiphospholipid syndrome. This all increases the risk of DVT by a factor of 20 to 80. Now, two epidemiological details that occasionally surface in different areas. First, DVT is slightly more common in women aged 20 to 45, but more common in men between 45 and 60. And if you exclude the female specific factors of pregnancy and the oral contraceptive pill, the incidence is higher in men in every age group. Second important thing is there is a genuine seasonal variation with VT incidence peaking in the winter, especially in February. Alright, now we'll talk about the pathophysiology and natural history. In 1856, Varco described the three conditions that predispose to thrombosis, and they remain the framework we use still today. Impaired venous flow or stasis, injury to the vein wall, and increased procoagulant activity in the blood. which is thrombophilus. So the varicose triad: stasis, vein wall injury, and thrombophilus. Now let me precise about where a lower limb DVT actually begins. The great majority of lower limb thrombi start in the cuff, and specifically in the two places where blood flow is slowest. The first is the pocket behind each venous valve cusp, which is a small cul-de-sac where blood eddies rather than flows. The second is the soleal sinuses, the large, thin-walled, valveless venous sinusoids that sit within the belly of the soleus muscle and which are emptied only by contraction of the calf muscle pump. So when we say that the stasis originate in the soleal sinuses, what we mean is this: when the patient stops walking, that is either anesthetized on an operating table or confined to a hospital bed or immobile on a long-haul flight, the calf muscle pump stops working. Those muscular sinuses no longer empty, and blood pools within them and within the valve pockets. And that is where the thrombi first nucleates. That is the anatomical reason immobility is such a powerful risk factor. And it is why cuff DVT is the commonest starting point for what may later become an extensive proximal thrombosis. But stasis alone does not create a clot. Stagnant blood in a vein permissive, not causative. You can slow the flow considerably without producing thrombus. What converts stagnation into thrombus is what stagnation does to the vein wall. Blood trapped in the valve pocket becomes hypoxic. The hypoxic endothelium switches from a quiescent anticoagulant surface to an activated prothrombotic one, and it expresses adhesion molecules, of which P-selectin is the key one. P-selectin recruits leukocytes and circulating tissue factor bearing microparticles onto the vein wall, and those microparticles both deliver tissue factor and impair fibrinolysis through plasminogen activator inhibitor. So the sequence to recite is immobility, then stagnation in the valve pockets and soleal sinuses, then local hypoxia, then endothelial activation, then P-selectin and microparticle recruitment, and then thrombus formation. And note that the vein wall injury in DVT is not a mechanical denuding injury like a wear or a balloon. It is functional activation of endothelium immediately adjacent to the valve or cusps. That distinction between systemic and local injury explains a classic orthopedic observation. Total hip replacement produces contralateral as well as ipsilateral DVT because the venodilatation of anesthesia and the systemic inflammatory insult act on both limbs. Whereas total knee replacement, the direct surgical trauma and the tourniquet are confined to one leg, and that produces essentially ipsilateral DVT only. Now, once the thrombus has formed, it either lyses, organizes, or propagates proximally. As it propagates, it increases outflow resistance and reduces outflow volume. Venous pressure rises, and that, together with perivascular inflammatory reaction, produces the pain, tenderness, and swelling. Symptoms typically settle as the inflammation subsides and disappear altogether if the vein recanalizes fully without structural damage to the wall or the valves. Be aware that up to 80% of the DVTs are not clinically obvious, with pain as the only feature, which is precisely why we do not rely on clinical assessment alone. Two anatomical points from the guidelines. First is the Meyer-Thurner syndrome, also called iliac vein compression syndrome. The right common iliac artery crosses and compresses the left common iliac vein, causing chronic fibrosis of the underlying vein, which is why iliofemoral DVT is more commonly on the left side. Second, and prognostically the more important, is the recanalization rates are about 80% in the calf veins but only 20% in the iliac segments, and that gradient is the key to natural history. The more proximal the thrombus, the less likely the vein is to clear itself, and the more likely the patient is to be left with fixed outflow obstruction, secondary valve damage, reflux, and post-thrombotic syndrome. Now, the prognosis therefore follows thrombus burden and level. Calf DVT carries the best prognosis. Femoropopliteal is the intermediate and iliofemoral is the most severe, because the common femoral, external iliac, and common iliac veins form the single outflow channel for the entire limb, and that is occluded. And you generate the highest venous pressure and the worst post-thrombotic morbidity. Know the 5-year figures of iliofemoral DVT treated with anticoagulation alone, because they are the whole rationale for early thrombus removal, which is 95% develop venous insufficiency, 40% venous claudication, and 15% ulceration. 15% also had a limited ambulation, and most have a markedly reduced quality of life. And these are all for the proximal iliofemoral DVTs. The principle that ties this together is a time principle. Rapid resolution preserves valve function. If the thrombus clears within 2 to 3 months, the valve leaflets recover and remain competent. Beyond 3 months, the leaflet become entrapped in fibrotic organizing thrombus and is permanently incompetent. Consistent with that, the first signs of post-thrombotic syndrome usually appears within 3 months of the acute event and can then progress and deteriorate for years. Alright, we will now talk about the classification. We classify DVT along 2 independent axes: anatomical, where is the clot, and etiological, why did the clot happen. Both axes change management, and they change different parts of it. Let me take them one at a time. The first axis is anatomical. Thrombosis of the iliac, femoral, or popliteal veins is classified as proximal DVT. And note the rule, it is proximal regardless of whether there is concomitant calf thrombosis or not. Proximal DVT is then subdivided into iliofemoral and femoropopliteal DVTs. Thrombosis confined to the calf veins is distal or calf DVT, and that can be axial, which mean the peroneal or posterior tibial veins, or could be muscular, which means the soleal or gastrocnemius veins, or both. Roughly 30% of DVTs are isolated calf and roughly 30% involve the iliofemoral segment. Now the anatomical level really matters because the risk of pulmonary embolism, the risk of post-thrombotic syndrome, and overall prognosis all differ by level. And because iliofemoral DVT is the one subset in which early thrombus removal is recommended. The second axis, which we talked about earlier, is etiological, and this is the one that causes confusion. So let me explain this further. Number one, every DVT is either unprovoked or provoked. Unprovoked means no clear identifiable environmental or acquired risk factor. Provoked means there is one risk factor. That is the top of the three, and we defined it earlier already. Next, take the provoked part and split it into two. That is, the provoking factor could be either transient or persistent. Transient means the factor was present around the time of the clot and has since resolved. The operation is over, the pregnancy has ended, the plight was last month. Now, these are all transient and that is over. Now, let's talk about the persistent. Persistence means it is still there and will remain. So persistent factors are first, such as cancer, where the cancer has not received potentially curative treatment, or there is evidence that treatment has not been curative, or treatment is ongoing. And another one is any ongoing non-malignant condition that carries at least a twofold risk of recent VTE after anticoagulation is stopped, with inflammatory bowel disease as the standard example. Next, we talk about the transient part and split it into two again, which is major and minor. This split is purely about how powerful the trigger was. The guideline defines it numerically, which is worth quoting. A major transient risk factor is one that increases the risk of a first VT more than tenfold, and that occurred up to 3 months before the event. Having had 1/2 the risk of recurrent VT after stopping the anticoagulation compared with having had no transient factor at all. A minor transient risk factor increases the risk of first VT 3 to 10-fold and must have occurred within 2 months of the event. So, the major transient factors are surgery under general anesthesia lasting more than 30 minutes, acute illness confined to bed in hospital for at least 3 days, cesarean section, estrogen therapy, pregnancy or the puerperium. These are all major transient factors. Now let's talk about the minor transient factors are surgery under general anesthesia lasting less than 30 minutes, hospital admission for less than 3 days with an acute illness, and confinement to the bed out of the hospital for at least 3 days with an acute illness, and leg injury associated with reduced mobility at least 3 days. Note the pattern because it makes the two lists easy to remember. The same trigger appears in both sides, and what separates them is the duration, how long the operation, how many days in the bed, and whether those days were in the hospital or at home. And why do we do all this? Because these runs in a straight line to the duration of anticoagulation. And I will restate this later in the episode. A major transient factor that has resolved gives the lowest recurrent risk, 3 months and stop. A persistent major factor such as active cancer or a severe thrombophilia gives the highest risk, so indefinite anticoagulation. Unprovoked DVT sits high with a recurrent risk that does not fall away with time. That's why you need extended anticoagulation if the bleeding risk permits. And provoked DVT with a minor transient or minor persistent factor behaves almost identical to unprovoked DVT, with recurrence rates that are not significantly lower, so those patients may also benefit from extended treatment. And that is the point of this classification. It is not just a classification system, it is a treatment duration algorithm. Okay, now we'll talk about the diagnosis. Clinical diagnosis alone is unreliable in both directions. Several conditions mimic DVT, including lymphedema, superficial vein thrombosis, post-thrombotic syndrome, cellulitis, a ruptured Baker cyst, and trauma, while up to 80% of true DVT have no obvious clinical signs. So the guideline makes 2 class 1 recommendations before you order anything. First, assess pretest probability using validated tool. And this is important to make sure that everyone uses the same validated diagnostic pathway. There are 3 steps. First, this probability tool, then D-dimer, and then imaging. Step 1 is the Wells score, that is the probability of the DVT. 9 clinical features, each score 1 point, such as active cancer, that is the treatment within the previous 6 months or ongoing palliative treatment, paralysis, paresis or recent cast immobilization of the lower limb, recently bedridden for 3 or more days, or a major surgery within the previous 12 weeks, requiring general or regional anesthesia, localized tenderness along the distribution of the deep venous system, entire leg swelling, calf swelling at least 3 centimeters, greater than the asymptomatic side, measure 10 centimeters below the tibial tuberosity. Pitting edema confined to the symptomatic leg, unilateral non-varicose collateral superficial veins, and previously documented DVT. Then one feature subtracts 2 points, which is an alternative diagnosis at least as likely as DVT. So the total runs from -2 to 8. Now the interpretation, and this is very important to know. There are 2 category or dichotomized version. Use a single cutoff of 2. A score of 2 or more means DVT is likely. A score of less than 2 means DVT is unlikely. The guideline also have a 3 category version, which divides the same score in 3 ways. 3 or more is high probability, 1 to 2 is moderate, and 0 or less is low probability. In the original validation, DVT was confirmed in about 85% of the high group and 33% of the moderate group and only 5% of the low group. If you are asked which to use, I would say the dichotomized, that is the 2 category version. It is simpler, it is more widely used, and it is what sits in contemporary pathways including NICE guideline. And stratifying into 3 groups has not been shown to offer any significant advantage. So 2 or more DVT likely, less than 2 DVT unlikely. And also know the caveat that the guideline is explicit about, and there is also a caveat that you need to know. Even in the low probability group, the reported probability of DVT can be as high as 5%. That is far too high to discharge a patient on. So the Wells score never confirms and never excludes a DVT on its own. It is not a standalone test. All it does is tell you which pathway the patient goes down. However, used in conjunction with D-dimer and ultrasound, it is an excellent tool. So, the next step then comes is the D-dimer. D-dimer is the fibrin degradation product raised in any condition with increased fibrin formation. The commonly used quantitative assays have a sensitivity of about 95% and a negative predictive value of 99 to 100%. So a negative result is very powerful, but the specificity is only 35 to 55%. So a positive result tells you very little. False positives are common with infection, cancer, pregnancy, and increasing age. And although age-adjusted cutoffs have been introduced, specificity remains poor at around 51%. False negatives do occur, particularly in patients already on anticoagulation and in isolated cuff DVT, where symptoms have been present for more than 2 to 3 weeks. So, combine steps 1 and 2 and the rule is simple. Wells unlikely plus a negative D-dimer excludes DVT. and do not need any imaging. Any other combination, likely on wells or a positive D-dimer or both, goes to imaging. So just to say again, wells shows the DVT unlikely and their D-dimer is negative, no need for any imaging. Okay, now the next step will come about the imaging, and ultrasound is recommended as the first line modality. And this is a class 1 recommendation. The diagnostic criterion is non-compressibility of the vein under probe pressure. Two techniques are in use and you must be able to distinguish them. 2 or 3 point compression ultrasound interrogates only the common femoral vein and the popliteal vein plus or minus the femoral vein. Whole leg ultrasound scans the entire deep venous network from the common femoral vein down to the distal calf veins. Each has its trade-off. Compression ultrasound is quicker, simpler, and more reproducible and does not require advanced venous ultrasound skills. But it cannot detect isolated calf DVT. So if the pretest probability is likely and a compression scan is negative, the ESVS guideline recommend repeating the ultrasound at 5 to 7 days, and this is a class 2A recommendation. Whole leg ultrasound, by contrast, can be considered conclusive after a single assessment, removing the need to rescan, and it may pick up alternative pathology in the limb, which is why when calf DVT is suspected, whole leg ultrasound is recommended, and this is a class 1 recommendation. The counter argument is real. Whole leg scanning needs a skilled operator, better machines, and more time. And by detecting isolated calf thrombi of uncertain significance, it risks overdiagnosis and unnecessary anticoagulation. So, patient selection really matters. The Palladio algorithm is the elegant compromise, and it is worth being able to recite in 3 groups. Group 1, if you have the pretest probability unlikely and the D-dimer also negative, then DVT is literally excluded. You do not need to scan. Group 2, either the probability is likely or the D-dimer is positive but not both, then you do compression ultrasound only. Group 3, if the probability is likely and the D-dimer is positive, you need to do the whole leg ultrasound. In the study, 3-month thromboembolic events were negligible in Group 1 at under 0.3% and 1% in Group 2, and whole leg scanning was needed in only 35% of patients, of whom about half had a DVT. It is not yet formally validated, which is why the writing committee of ESVS guideline still favors whole leg ultrasound whenever calf DVT is suspected and the service is available. What about second-line imaging? Where ultrasound is inconclusive or not feasible in suspected proximal DVT, consider CT venography, MR venography, or conventional contrast venography. And this is a class 2A recommendation. CT and MR venography both have sensitivity and specificity comparable to ultrasound and offer a clear advantage when you need to see the pelvic veins or the inferior vena cava or to plan an intervention. However, the trade-offs are the cost, iodinated or gadolinium contrast, and for CT, its radiation. Now, contrast venography was historically the gold standard, but is now reserved only for inconclusive, non-invasive imaging or when a catheter-based intervention is planned in the same setting. An important thing to remember, suspected recurrent DVT in the same leg, duplex cannot reliably age a thrombus, so it cannot distinguish acute recurrent thrombus from a residual chronic thrombus in the segment. Where a whole leg ultrasound is inconclusive in this setting, consider magnetic resonance direct thrombus imaging, which can make that distinction. In the Thayer study, 119 patients with a negative scan were left off anticoagulation and the 3-month recurrent VT rate was only 1.7%. Okay, what else to test for? There are 3 areas which warrant your attention. Let's start with the pulmonary embolism. Do not routinely investigate the asymptomatic even though up to 30 to 40% harbor silent PE. What about the cancer? 4 to 12% of unprovoked DVT patients are diagnosed with cancer during treatment. So it's 4 to 12%. But extensive screening does not reduce mortality. So the recommendation is clinical examination plus sex-specific screening only. Do not do CT or PET. Now, what about thrombophilia testing? Do not test in provoked DVT. And also do not routinely test inherited thrombophilias in unprovoked DVT. However, do consider testing with unprovoked DVT and a first-degree family history. So if you have an unprovoked DVT and a first-degree family history, you do thrombophilia screen. It's very clear, right? And do consider antiphospholipid antibodies if contemplating stopping anticoagulation. So you only consider antiphospholipid antibodies screening if you are planning to stop anticoagulation. As you know, this is very high-risk thrombophilia. Okay, now there are some specific points that you also need to know. Antithrombin deficiency gives a 5 to 20-fold risk. Protein C deficiency risks warfarin-induced skin necrosis. Factor V Leiden is the commonest and 5-fold in heterozygous and 80-fold in homozygotes risk of DVT. Can you see 80-fold in homozygotes? Catastrophic antiphospholipid syndrome carries a 50% mortality. So this is a very serious thrombophilia. Always be mindful about antiphospholipid syndrome. Never test in the acute phase. If you are to do thrombophilia screening, you need to wait 2 weeks after warfarin, which is VKA, or 3 days after DOAC, and confirm phenotypic test on a second sample. Okay, now we'll talk about the management and starting with the anticoagulation. Treatment runs in 3 phases. So if you are to start the treatment, you start the anticoagulation, and this runs in 3 phases. An initial phase up to 10 days, the principal phase of the first 3 months, and the extended phase beyond 3 months, with no scheduled stop. Indirect anticoagulants need antithrombin for their function, such as unfractionated heparin and low molecular weight heparin. The unfractionated heparin inhibits factor 2A and 10A as 1:1, whereas low molecular weight heparin shifts the ratio towards factor 10A, which means they inhibit factor 10A more. Fondaparinux inhibits only factor 10A. And warfarin, which is VKS, inhibit gamma carboxylation of factor 2, 7, 9, 10, protein C, and protein S. Direct anticoagulants need none. They do not need antithrombin 3 for their action, such as dabigatran, which inhibits thrombin directly, and apixaban, edoxaban, and rivaroxaban inhibit factor 10A, that is factor XA, and that's why their name is XA-ban. Low molecular weight heparin is preferred over unfractionated heparin initially and needs a 5-day overlap with warfarin, which is VKA, and is a treatment of choice for cancer DVT. Fondaparinux causes essentially no HIT, that is heparin-induced thrombocytopenia. Warfarin gives an initial procoagulant state because protein C and S have short half-lives, so always overlap with heparin. Keep the INR at least 2 for 24 hours before stopping heparin. And remember, it is teratogenic. Now let's talk about the doses. Unfractionated heparin is, you remember, 80 and 18. So unfractionated heparin is an 80 unit per kilo bolus and 18 unit per kilo per hour as a maintenance. Targeting an APTT ratio of 1.5 to 2.5 and anti-XA level of 0.3 to 0.7. A subtherapeutic level early carries a 15-fold recurrence risk. And if you want to reverse this, you reverse with protamine. Now, low molecular weight heparin is weight-adjusted subcutaneous dosing, and this monitored in pregnancy and morbid obesity, only partially reversed by protamine. Fondaparinux is 7.5 milligrams once daily, 5 under 50 kilos and 10 over 100 kilos. So average is 7.5, but if someone is under 50 kilos, you give 5 milligram, and someone is over 100 kilo, you give 10 milligrams. And fondaparinux is contraindicated below a renal clearance of 30. Dabigatran is 150 twice daily after 5 parenteral days and 110 if 80 or over on verapamil. Edoxaban is 60 mg once daily after 5 parenteral days. Apixaban is 10 twice daily for 7 days, then 5 twice daily, and extended dose 2.5 twice daily. So remember the apixaban, it's 10 mg twice daily for 7 days, then 5 mg twice daily up to 3 months. If you need an extended dose, then you only go to 2.5 milligram twice daily. Now about rivaroxaban, it's a 15 milligram twice daily for 3 weeks, and then 20 once daily with food, and if you need extended dose, then 10 milligram once daily. So importantly, apixaban and rivaroxaban need no parenteral lead-in. That means you don't need to cover initial 5 days with parenteral cover. Dabigatran and edoxaban need at least 5 days of parenteral anticoagulation. Now, if you need to know few important things, the bioavailability is 100% for edoxaban, and the second highest bioavailability is for rivaroxaban, which is 80%, whereas apixaban is only 50% and dabigatran only 6%. So edoxaban has 100% bioavailability and rivaroxaban has 80%. If we talk about the half-life, the shortest half-life also goes to edoxaban. So bioavailability 100% for edoxaban, but the half-life is 6 to 12 hours. And rivaroxaban again is 80% bioavailability and the half-life is only 7 to 11 hours. If you see the renal clearance, dabigatran is the one that is highest clearance via kidneys, and that's 80%. So dabigatran has 80% renal clearance. Next is edoxaban, 62%, and then rivaroxaban, 35%, and apixaban, 27%. So apixaban is much more safer to use in renal patients. Another important thing to remember, the dabigatran is the only prodrug. The other three, that is apixaban, edoxaban, and rivaroxaban, these are not prodrug. So dabigatran itself is a prodrug, and dabigatran directly inhibits thrombin, whereas apixaban, edoxaban, and rivaroxaban, they inhibit factor 10A. Okay, now we'll talk about bleeding, reversal, and HIT, that is HIT, heparin-induced thrombocytopenia. Now, DOACs carry a lower bleeding risk than warfarin and low molecular weight heparin. Major bleeding relative risk is 0.61, intracranial is 0.37, and fatal is 0.36. Though GI bleeding may be higher with dabigatran, rivaroxaban, and edoxaban. Reversal is agent-specific. For VKA, 4-factor PCC at 25 to 50 units per kilo plus 5 mg of IV vitamin K. PCC is preferred over fresh frozen plasma. So again, if you want to reverse warfarin, you need a 4-factor PCC 25 to 50 units per kilo plus 5 mg of IV vitamin K. For unfractionated heparin, you need protamine to reverse. For low molecular weight heparin, you also need protamine, but only partial reversal happens. For fondaparinux, you need recombinant factor 7A. For dabigatran, you need idarucizumab for reversal, and that is 2.5 gram IV doses, giving 100% median reversal. So if you want to reverse dabigatran, you can do 100% reversal by idarucizumab. For the XA inhibitors, endexanate alpha as a bolus plus 2-hour infusion with 4-factor PCC at 50 units per kilo as fallback. So if you want to reverse any XA inhibitor such as apixaban, rivaroxaban or edoxaban, you need andexanet alpha, and this should be as a bolus plus 2-hour infusion with 4-factor PCC at 50 units per kilo as fallback. For warfarin at a high INR over 5 without bleeding, withhold doses and reduce maintenance. So if you have INR over 5 but there is no bleeding, you just withhold doses and reduce maintenance. If it is over 8, you go for oral vitamin K. Now, this is very important to know. For warfarin reversal at a high INR over 5 without bleeding, you withhold the doses and reduce the maintenance. Over 8 with no bleeding, you only go for oral vitamin K. Non-major bleeding over 8, you go for IV vitamin K. If it's over 8 but major bleeding, then you need a PCC plus IV vitamin K, which we mentioned earlier. And this should be 4-factor PCC. So we say again, warfarin, INR more than 5, no bleeding, you omit doses and you reduce the maintenance doses. INR over 8, no bleeding, you need only oral vitamin K. INR over 8 but non-major bleeding, you need IV vitamin K. INR over 8 but major bleeding, you need 4-factor PCC plus IV vitamin K. Okay, now let's talk briefly about HIT, that is heparin-induced thrombocytopenia. And it has a score which we call 4T's score, that is thrombocytopenia with a greater than 50% drop and nadir of 20,000. So if you have a HIT, you need to know about this 4T's score, that is thrombocytopenia with a greater than 50% drop and nadir over 20,000. Timing with a clear onset on day 5 to 10 or under 1 day with recent heparin exposure. Thrombosis or sequelae such as new thrombosis or skin necrosis, and no other causes apparent. So these are the 4 T's. 1 of 3 is low with a negative predictive value of 99.8%. 4 to 5 is intermediate and 6 to 8 is high predictive value. Unfractionated heparin carries a 10-fold higher HIT risk than low molecular weight heparin, and fondaparinux does not carry any risk of HIT. And treatment of HIT is argatroban or danaproid. Remember these two. If you have a HIT, you treat with argatroban or danaproid, and argatroban has a short half-life and target an APTT of 1.5 to 3 times baseline, and it is safer in renal insufficiency. So argatroban is much more safer than danaproid in renal insufficiency. Okay, now we'll talk about duration and risk stratification. The duration depends on whether the event was provoked or unprovoked. For provoked DVT with a major transient risk factor, 3 months is recommended over shorter and preferred over 6 or longer months. For a persistent non-cancer factor, consider beyond 3 months with reassessment. For unprovoked DVT, recurrence is high and persistent in men, about 12% at 1 year, rising to 41 at 10 years. In women, 9 rising to 29 at 10 years. Here is an important thing that you need to know. Even after 12 months of anticoagulation, once you stop, recurrent matches stopping at 3 months. So, initial duration does not change eventual risk. So, extended anticoagulation is recommended if bleeding risk is low or moderate. DOACs are preferred for extended anticoagulation over warfarin, and beyond 6 months, a reduced dose of apixaban, that is 2.5 twice daily, or rivaroxaban 10 mg once daily should be considered. For extended anticoagulation, you either go for reduced dose of apixaban, which is 2.5 BD, or rivaroxaban 10 mg OD. Aspirin is not recommended. It gives only 38% risk reduction versus 84 to 91% for DOACs and VKs. At the bedside, use the 3-tier stratification. If the patient is high risk, that means indefinite anticoagulation unless bleeding risk is high. The high risks are active cancer, a persistent major factor such as chronic rheumatic disease, or severe thrombophilia, including antithrombin deficiency, antiphospholipid syndrome, homozygous factor V laden, or prothrombin 20,210, or combination thrombophilia. For the intermediate risk patients, they're considering extended therapy with the lowest bleeding risk DOAC. The intermediate risk patients are recurrent VTEs, an unprovoked event, a minor transient factor, male sex, obesity, or significant comorbidities. Now, for the low-risk patients, stopping at 3 months is recommended. A clear major transient factor, hormonal therapy now stop, pregnancy or puerperium, and a calf DVT. These are all low-risk patients. Now, there are 3 named models which support these risk tier stratification management. This is called HER2, and this keeping all men on an indefinite treatment while low-risk women can stop. The Vienna model using sex index site and D-dimer, and the DASH score, that is D-dimer abnormal, age under 50, sex male, and hormone use. Okay, now we'll talk about compression therapy. Compression has both an acute and long-term role, and it is a point where NICE and ESVS diverge. In the acute phase, early compression at 30 to 40 mm of mercury, multi-layer bandage, or hosiery applied within 24 hours is recommended to reduce pain, edema, and residual vein obstruction. This showed a 51 to 55% relative risk reduction in PTS with stocking and early ambulation. Okay, I just say it again. and early ambulation adds no PE risk. For PTS, prevention specifically, below-knee stocking should be considered. So remember again, below-knee pressure of 30 to 40 mm mercury, and that should be applied within 24 hours, and that is the recommendation. Now, very important topic to remember is post-thrombotic syndrome. We'll give a bit more attention on this. Post-thrombotic syndrome is the reason almost everything else in this episode exists. It is the most frequent complication of DVT, affecting 20 to 50% of patients within 1 to 2 years after acute DVT, and it is the endpoint against which every intervention we have discussed, anticoagulation, compression, thrombus removal, and these ultimately judged. We will define it properly. Post-thrombotic syndrome is a chronic condition of venous insufficiency in a limb that has previously sustained a DVT. And this is characterized by a variable combination of pain, leg heaviness, discomfort, pretibial edema, skin ulceration, hyperpigmentation, and in the most severe cases, venous ulceration. There are three components in that sentence. It is chronic, it follows a documented DVT in that leg, and it is a spectrum from mild symptom to ulceration. The pathophysiology is chronic venous hypertension produced by three mechanisms acting together. First is the outflow obstruction from a vein that never fully recanalized. Second, valvular reflux from leaflets destroyed or entrapped by organizing thrombus. Third, vein wall remodeling and fibrosis. Obstructing plus reflux is worse than either alone, and it is the combination that produces the highest ambulatory venous pressure, which is why post-thrombotic limbs behave so much worse than limbs with primary varicose veins, which has no obstruction, only has valvular incompetence. The risk factors are worth listing because several are modifiable: older age, obesity, a previous ipsilateral DVT, so recurrence in the same leg, proximal and specifically iliofemoral DVTs, pre-existing venous primary incompetence, and inadequate anticoagulation during the first 3 months of treatment. This could be subtherapeutic anticoagulation or not enough duration, and this risk a PTS. Now the Villalta scale. We'll talk about this because this often comes in exam. It has 11 items scored 0 to 3, either absent or mild or moderate or severe. That is 0, 1, 2, and 3. Plus a 12th, which is binary item, that is ulceration, whether you have ulceration or not. So 11 items plus ulceration. 5 are subjective symptoms reported by a patient, such as pain, cramps, heaviness, paresthesia, and pruritus. And the 6 are objective signs elicited by you, that is pretibial edema, skin induration, hyperpigmentation, redness, venous ectasia, and pain on cuff compression. These 11 items at 3 points each gives a maximum of 33 points. And then you record the presence or absence of a venous ulcer separately. The threshold, commit these to memory. This is very important for the exam because they drive both diagnosis and the compression algorithm. A score under 5 is not PTS. 5 to 9 is mild PTS. 10 to 14 is moderate. 15 or more is severe. And importantly, the presence of a venous ulcer makes it severe regardless of the numerical score. So if there is an ulcer, it is severe, does not need any other criterion. Otherwise, if you have a score of 15 or more, it is severe. Now, 2 practical caveats about using it. First, you cannot diagnose PTS in the acute phase because acute DVT itself produces pain, edema, and tenderness and would score highly. That is why the assessment schedule starts at 3 months. The second caveat is the Villalta score is not specific. It will pick up symptoms from pre-existing primary venous disease in the same leg, so it needs a documented ipsilateral DVT to be interpretable, and comparison with the other leg is always useful. So, what do we do about established post-thrombotic syndrome? How do you manage it? Always be honest by saying what the guideline tells you. There is currently no cure for PTS. And that single sentence is why the entire emphasis sits on prevention, but not on cure. However, no cure is not the same as nothing to offer, and you should be able to give a structure management plan in 4 tiers. First tier, before you treat anything, confirm what you are treating. Is it new or worsening symptoms in a post-thrombotic limb or recurrent DVT until proven otherwise? And duplex alone cannot age a thrombus, which is why we discussed MR direct thrombus imaging earlier. Establish the anatomy properly, which segments are occluded, which are recanalized, is there reflux, is there superficial incompetence as well. And review the anticoagulation. Is it adequate? Is the indication of extended treatment still correct? And so on. Next, the tier 2, very important, is conservative management, which is the first line for everyone. Graduated below-knee compression at 30 to 40 millimeters of mercury is the backbone. In a grossly edematous or ulcerated limb, start with inelastic multi-layer bandaging to strip out the edema and only then fit hosiery. Because a stocking measured on a swollen leg will never fit the decongested one. Intermittent pneumatic compression is an option for severe or refractory PTS and for venous claudication. Add supervised exercise calf muscle pump and ankle mobility training genuinely improve pump function and quality of life and do not aggravate symptoms. After doing all this, you also have to focus on weight reduction, leg elevation, meticulous skin care, and emollients, and also prompt treatment of cellulitis if there is any. Venoactive drugs and pentoxifylline in the context of ulceration may be used as adjuncts, but these are adjuncts to the compression, not alternatives. Next tier of management, that is tier 3, is important as well, and this is where vascular surgery comes in place. Identify the patients whose disease is anatomically correctable. The question to ask, is this limb obstruction dominant, or is it the reflux that is dominant, or is it both? Obstruction dominant disease, the patient with venous claudication, a whole limb swelling, and a chronically occluded or stenosed iliocaval segment. And these are the group that benefits most from deep venous stenting. And I will take you through the investigation and technique in detail in the next part of this episode. Reflux dominant disease with a patent deep system and significant superficial incompetence may benefit from ablation of the incompetent superficial veins, which improves ulcer healing and reduces recurrent. But one absolute warning: never ablate superficial veins that are functioning as collaterals around an occluded deep system. In that case, you will make the limb dramatically worse. That is why the deep system must be imaged before you touch the superficial veins. The next tier of management, that is number 4 category, is the small group that is left over is deep valve reconstruction or valve transplantation for severe reflux dominant PTS. And this should be done only in specialist centers with limited durability. Open venous bypasses, that is the Palma crossover and its variants, only for iliocaval obstruction and not amenable to or failed by endovascular treatment. And for the venous ulcer itself, compression remains the single most effective intervention for healing, supported by wound care and correction of superficial reflux if there is any. So the take-home line for the exam is: post-thrombotic syndrome cannot be cured, so all of the leverage sits upstream, that is adequate anticoagulation in the first 3 months, early compression within 24 hours, and selective and early thrombus removal in the patients with the most to lose, which is exactly where we go next. Okay, so now we will talk about early thrombus removal, and this is core for iliofemoral DVT management. We'll talk about the rationale, how you select the patients, and what are the techniques. So we'll talk about the rationale, how you select the patient, and also about the techniques. Okay, so early thrombus removal is the most heavily examined area in venous surgery. And the reason is that the evidence is genuinely contradictory. Let me explain this in 4 parts: the rationale, the patient selection, the techniques, and then we will talk about the trials. Let's start with the rationale. The rationale rests on what is called the open vein hypothesis. The argument runs like this: persistent thrombus in a vein provokes a chronic inflammation reaction. That inflammation destroys the valve leaflets and drives fibrotic remodeling of the wall. The vein is left obstructed and refluxing, and the resulting ambulatory venous hypertension produces post-thrombotic syndrome. Therefore, if you remove the thrombus early, before the valves are destroyed and before the wall is fibrosed, you should preserve valve function and preserve outflow and prevent PTS, right? Okay, now let's talk about the supporting numbers, and these are the ones I gave you earlier. They are worth repeating because they are the entire justification for taking any bleeding risk at all. Post-thrombotic syndrome develops in 25 to 75% of the patients with extensive DVT even after optimally delivering anticoagulation. And at 5 years after iliofemoral DVT treated with anticoagulation alone, 95% have venous insufficiency and 40% have venous claudication, and 15% have ulceration, and another 15% have limited ambulation. And if you add the time principle, thrombus cleared within 2 to 3 months allows valve leaflets to recover. Thrombus persisting beyond 3 months entraps and destroys them. And the case of early intervention in the right patient becomes obvious. There is also a dose-response observation that supports this hypothesis. Residual thrombus correlates directly with post-thrombotic morbidity. Patients achieving 90% or greater lysis have essentially no PTS, and rethrombosis runs at about 5% in those left with under 50% residual thrombus versus 38% in those left with more. In other words, if you are going to do it properly, a partially cleared vein is a poor outcome. Now, what about the selection? Okay, now we will talk about the selection. Because selection is genuinely the whole game here. The patient at highest risk of severe PTS are the extensive thrombus burden involving the iliofemoral segment, severe symptoms, a first episode of DVT, good functional status and ambulation, and reasonable life expectancy. Iliofemoral means the common femoral and external iliac or common iliac vein, the single outflow channel for the whole limb. Femoropopliteal DVT does not qualify, and that is a formal class 3 recommendation. So do not do thrombus removal for FemPop DVTs. Now we will talk about the highest chance of technical success. That means it needs to be acute thrombus, which means symptom onset within 14 days, not established post-thrombotic lesion on imaging, because organized chronic thrombus does not lyse, and attempting it exposes the patient to the bleeding risk with none of the benefits. Next criteria for patient selection is the lowest bleeding risk. Screen for recent surgery or major trauma, active or recent gastrointestinal bleeding, recent stroke and intracranial pathology, uncontrolled hypertension, and pregnancy. Balance those explicitly and say you are balancing them. Because the meta-analysis shows 5-fold increase in major bleeding with these techniques. And finally, one situation that overrides all the 3 selection criteria is phlegmasia, cerulear dolens, or a threatened limb. Their thrombus removal is limb saving, and here the thrombus removal is limb saving and the calculus changes entirely. Now if we talk about the technique, there are 3 options and you should be able to describe each. So we will start with open surgical venous thrombectomy. This is performed under general anesthesia through a common femoral venotomy using a Fogarty catheter to extract thrombus from the iliac segment and the cava, while distal thrombus is expressed by manual massage or an Ishmark bandage, which is applied from the foot upwards. In modern practice, you can add fluoroscopic guidance, completion phlebography, and correction of any residual iliac stenosis with a stent, which has largely replaced the traditional arteriovenous fistula in the groin. The historical evidence is that Swedish randomized trial by Plate at 10 years patency was 83% after thrombectomy versus 41% with anticoagulation alone, with less leg swelling. And more recently, a comparative study showed surgical thrombectomy non-inferior to thrombolysis with 85 versus 87% free of PTS at 2 years. Its place today is where lysis is contraindicated in phlegmasia and after failed endovascular treatment. Next modality is catheter-directed thrombolysis. A multiple side hole catheter is placed directly into the thrombus, usually via a popliteal vein puncture under ultrasound guidance with the patient prone, and note that even a thrombosed popliteal vein can be accessed successfully. The posterior tibial vein and the small saphenous vein are alternatives. A plasminogen activator, usually recombinant tissue plasminogen activator, that is RTPA, is infused into the clot, and the dose should not exceed 1 mg per hour, alongside weight-adjusted heparin. The patient is monitored with repeat venography every 12 to 24 hours, and treatment typically takes 2 to 3 days. 2 technical refinements worth knowing. Pulse spray delivery achieves better long-term primary patency and valve function than continuous infusion. An ultrasound-assisted thrombolysis, despite the theory, showed no advantage over standard catheter-directed thrombolysis in a randomized comparison. Success rates are 80 to 90%. However, major bleeding is 2.2 to 3.3%. Peri-procedural PE has not proved to be a significant concern, and stenting rates after lysis range from 17 to 80% across series. The third is the pharmacomechanical. That is the catheter-directed thrombolysis, which combines the lytic infusion with a mechanical device. This could be a rheolytic thrombectomy, isolated segmental pharmacomechanical thrombolysis, or aspiration. The rationale is speed and a lower lytic dose. In the PEARL registry of 329 patients, 73% completed treatment within 24 hours, which is against the 2 to 3 days for conventional lysis we just mentioned. Be aware of the specific complications of a rheolytic device. That could be hemoglobinuria, bradyarrhythmia, and renal injury. And note that purely mechanical disruption without lytic agent is minimally effective. The newer large bore aspiration thrombectomy devices are promising, but currently lack high quality prospective evidence. Now we will talk about the evidence base for early thrombus removal. There are 4 randomized trials that define this field, and I want you to know about all these trials. There's the Torpedo trial that published by Sharifi, and that randomized 183 patients with any proximal DVT to percutaneous endovenous intervention plus anticoagulation versus anticoagulation alone, and reported reduction in both PTS and recurrent VTE. It is the smallest and methodologically weakest of the 4, so quote it but do not lean on it. Next comes the CAVENT, and this is one of the positive trials. So 209 patients with iliofemoral DVT or upper femoral DVT randomized to additional catheter-directed thrombolysis versus standard anticoagulation, with at least 6 months of anticoagulation in both arms. Iliofemoral patency at 6 months was 66 versus 47%, and the PTS at 24 months was 41% with lysis versus 56% without lysis, and an absolute risk reduction of 14.4%. Number needed to treat was only 7. And then the crucial long-term result, at 5 years, the absolute risk reduction had grown to 28% and the number needed to treat had fallen to 4. There was no difference in quality of life, though the trial was not powered for it, and a cost-effectiveness analysis gave an incremental cost-effectiveness ratio of about $20,000 per quality adjusted life year. Okay, now we'll talk about the ATTRACT trial, and this is one of the key paper. 692 patients with femoral or more proximal DVT were enrolled, so FEMPOP DVT patients as well as iliofemoral DVTs were also included. And these randomized to pharmacomechanical or catheter-directed thrombolysis versus anticoagulation alone. The primary outcome and any PTS between 6 and 24 months was completely negative, 47 versus 48%, and relative risk 0.96. Major bleeding within 10 days was higher, and 1.7 versus 0.3%. Recurrent VTE was numerically higher but not significant. 12.5 versus 8.5%. If you read the secondary outcomes, because this is where this become interesting, moderate to severe PTS was significantly reduced. 18 versus 24% relative risk, 0.73. Leg pain and swelling were significantly better up to 30 days, and the pre-specified iliofemoral subgroup, and these were published separately, which showed reduced PTS severity score and also reduced moderate to severe PTS and better quality of life. And this was without an increase in major bleeding. Meanwhile, the FEMPOP subgroup, published separately, showed no benefit at all, and that analysis is the direct basis for Class 3 recommendation not to treat the FEMPOP DVTs with lytic therapy. Now the next one comes as CAVA trial. 184 patients were included, and this time iliofemoral DVTs only, answering Attract's delusion criticism, and that randomized to ultrasound accelerated catheter-directed thrombolysis versus anticoagulation alone. At 12 months, PTS was 29 versus 35%, no significant differences statistically, but the trial took 7 years to recruit. Almost 12% of patients withdrew after consent randomization. Technical success in delivering lysis was low, and it used ultrasound-assisted lysis, which we already know confers no advantage over conventional catheter-directed lysis. So if you see, only the CAVENT that reduced the PTS significantly, and Attract reduced the severity of the PTS and the symptoms, but did not reduce the number of PTS. So if you talk about number of PTS was only reduced in CAVENT. Okay, now if we pull all these 4 trials and do a meta-analysis, which it shows for any PTS a relative risk of 0.67 favoring early thrombus removal, just reaching the significance. For moderate to severe PTS, a relative risk of 0.59, and that is a clear significant benefit with no heterogeneity between trials. And for major bleeding, a relative risk of 5.68 and a significant roughly 5-fold increase of major bleeding. So how do you reconcile CAVENT and Attract? If we say in 5 points, we can explain this. Number 1, the population. Attract diluted its cohort with FEMPOP DVT, a group we know that get no benefit from thrombus removal. CAVENT and CAVA studied iliofemoral disease only, restricted the analysis to iliofemoral, and the trials broadly agree. And number 2, I just repeat again, and number 2 is the endpoint. The Villalta score as a binary yes or no for any PT is not a correct way to measure it. When you look instead at moderate to severe PTS, the disease that actually matters to patients, and the benefit is consistent across trials and the meta-analysis. So instead of any PTS, should be focusing on moderate to severe PTS. Next point to mention is the intervention, which was incomplete. Stenting rates were only 17% in CAVENT and 39% in ATTRACT. Residual iliac stenosis left untreated is the commonest reason for early rethrombosis. So a large population of patients in both trials had the clot cleared, but the underlying lesion left in place. So if you see 17% in CAVENT and 39% in ATTRACT. Contemporary practice is to finish the job, clear the thrombus, then image and treat the outflow lesion if there is any identified. And note, there has never been a trial stenting versus no stenting after thrombus removal. That is an honest gap of knowledge. Next point is to remember the technology has moved. One device used in ATTRACT is no longer commercially available, and another has been superseded. So the trials do not represent current best practice. And next, number 5, last point is follow-up duration. PTS has a long development phase. In CAVENT, the benefit doubled between 2 and 5 years. In ATTRACT and CAVA, reported at 24 and 12 months respectively, which may simply be too early to capture the full effect. Which brings us to the 4 recommendation. In selected patients with symptomatic iliofemoral DVT, early thrombus removal should be considered, and this is a class 2A recommendation. For DVT limited to the FEMPOV or cuff veins, early thrombus removal is not recommended. For patients treated by early thrombus removal with or without stenting, anticoagulation should continue for at least as long as it would have if they had been treated by anticoagulation alone, and at the discretion of the treating physician. So whether you do thrombus removal or not, it has nothing to do with the duration of anticoagulation. The duration of anticoagulation is again at the discretion of the physician, as we discussed, by whether it's provoked, whether it's unprovoked, whether it's major or minor transient factors. That's all you need to decide on. Okay. And then finally, there is no evidence that stenting the iliac vein reduces the need for anticoagulation. The choice of specific technique rests on the judgment of treating physician, because no modality has been shown superiority to another. Okay, finally, the post-stenting anticoagulation regime. A systematic review of chronic deep venous obstruction found more than 10 different regimes in the literature, varying in agent, duration, and whether antiplatelet therapy was added, with no evidence supporting one over another. So the honest answer is continue anticoagulation as dictated by the DVT itself and antiplatelet therapy according to local protocol, and acknowledge that this is an evidence gap. If you are given the acute iliofemoral case in your exam, you need to mention that you resuscitate and assess the limb whether it's threatened or not, start therapeutic anticoagulation immediately before anything else, confirm the extent with whole leg duplex and a CT or MR venography to define the iliocaval segment, and look for a compressive lesion. Apply the 3 filters which we mentioned earlier. Is it extensive iliofemoral thrombus, symptoms within 14 days or not, and acceptable bleeding risk? If all 3 are satisfied and patient is young, active and symptomatic, discuss early thrombus removal, catheter directed or pharmacomechanical lysis, with the explicit intention of treating any residual iliac lesion. But stenting in the same sitting should be considered. And of course, compression within 24 hours, anticoagulation for at least as long as standard therapy, and follow-up with duplex surveillance and serial Villalta scoring. Okay, now we'll talk about the IVC filters, cuff DVT and phlegmasia. The sole purpose of IVC filter is prevention of PE, not treating the DVT. You all know that. The sole purpose of an IVC filter is prevention of PE. We all know this is not to treat the DVT. PREPIC study randomized 400 patients to a permanent filter or none. At 12 days, PE was 1.1 versus 4.8%, but at 2 years, recurrent DVT was significantly higher with a filter, and that is 20 versus 11, with no survival benefit. Absolute indications for IVC filters are inability to anticoagulate a patient with DVT or PE, PE despite adequate anticoagulation, and an anticoagulation complication that forcing cessation of anticoagulation. So there are 3 absolute indications, and these are: number 1, if you cannot anticoagulate a patient with DVT or PE, such as a patient who is having DVT and also having a placenta previa or placenta accreta, then you cannot anticoagulate. Okay. Then there is another indication when a patient with DVT or PE having repeated I just say the whole sentence again. So there are 3 absolute indications for IVC filter. Number 1, inability to anticoagulate. So if there is any contraindication to anticoagulate in a patient with DVT or PE. A patient with DVT or PE despite adequate anticoagulation. Number 3 is an anticoagulation causing complication which forces cessation, such as major bleeding. So, a temporary IVC filter is recommended for proximal DVT with a contraindication to anticoagulation, but routine filters in anticoagulated patients are not recommended. And these should be retrievable filters. A study showed retrievable filters fracture in 25 to 50% and are retrieved in only 4 to 38% patient. So whoever places one owns its retrieval. Now, if we talk about the cuff DVT, this involves the deep cuff veins. Propagation to popliteal or above is around 9%, and the PE rate is about 1.5%. base the decision to anticoagulate on symptom propagation risk and bleeding risk. If you anticoagulate, 3 months is recommended with the single reception that single vessel post-operative cuff DVT may be treated for 6 weeks. DOACs are preferred over low molecular weight heparin or warfarin. Consider beyond 3 months in active cancer, and if not anticoagulating, repeat whole leg ultrasound at 1 week. Finally, recognize phlegmasia instantly. Alba dolens is the white leg of major deep vein thrombosis, while cerulear dolens is the blue leg of total outflow obstruction with cyanosis, massive congestion, and shock, risking compartment syndrome and venous gangrene. Treat cerulear dolens with immediate weight-adjusted heparin, leg elevation, fluid resuscitation, escalating to catheter-directed thrombolysis, PCDT, thrombectomy, and iliac stenting, because anticoagulation alone carries amputation rates to 50% and mortality to 40%. Okay, even though we are discussing about DVT, let's briefly talk about superficial vein thrombosis. Do not dismiss superficial vein thrombosis. In the post-study, 25% already had a DVT extension or PE at diagnosis, and 10.2% developed thromboembolic complications by 3 months. High-risk features are extensive or thigh-level thrombosis, great or small saphenous involvement, proximally within 3 cm of the junction, cancer, and thrombophilia. Diagnose with bilateral whole-leg ultrasound to exclude concurrent DVT, which is non-contiguous in up to 42%. Treatment runs by length and proximity. Under 5 cm with no high-risk feature needs no anticoagulation. 5 cm or more and 3 or more cm from the junction is treated with fondaparinux 2.5 mg once daily for 45 days. With intermediate dose of low molecular weight heparin as an alternative, and within 3 cm of the junction of saphenofemoral junction warrants therapeutic anticoagulation, and you treat like a DVT. Callisto showed fondaparinux cut the composite endpoint to 0.9 versus 5.9%. And Surprise trial showed rivaroxaban non-inferior to fondaparinux, though it is unlicensed for SVT. Ablation of incompetent vein should wait at least 3 months after the event. So you should not ablate within 3 months of an acute superficial vein thrombophlebitis or superficial vein thrombosis. I just say it again, the whole sentence. Ablation of incompetent veins should wait for at least 3 months after the acute event. So you should not ablate the superficial vein after having an acute superficial thrombosis within 3 months. It should be after 3 months. Okay, that is where I'm going to pause. DVT is one of the biggest chapters in the curriculum, and it is examined in the paper, the clinical scenarios, and the viva. So rather than rush it, I have split this episode into 2 halves and given it the time it deserves. In the second half, we will talk about upper extremity DVT in proper depth, Paget-Schroeder, thrombolysis, first rib resection, and then whole of the chronic deep venous obstruction as well. From May-Thurner to IVUS guided stenting, we will finish with NICE versus ESVS, a full take-home summary, and the rapid-fire questions. The upper limb and chronic obstruction are both heavily examined, so you make sure you come back to it in our next part. Thanks again for listening to Proximal Control Vascular Surgery Exam Prep. As always, with your support, we will grow together. Keep listening to Proximal Control because in vascular surgery, control is everything.